area. And then at the end, I'm going to talk about a little bit about what the future holds and perhaps how some of us may collaborate going forward on an international level. So let's kick off. So what exactly is the problem? So our population is aging, and that is the same worldwide. And we all know that the risk of breast cancer increases with age. So we are facing a bit of an aging crisis in general, but the number of people living with breast cancer is going to significantly increase. And this is an estimate from the World Health Organization. At the moment, there's just over 400,000 new cases of breast cancer diagnosed each year worldwide in women over 70, and that's going to increase to over 1 million cases by 2040. So the number of older women living with and diagnosed with breast cancer per year will increase. The way of looking at that is in this diagram from the Global Cancer Observatory. At the moment, on the left, you can see the number of new cases. This is in women aged 65 to 85 per year, and this is almost doubling by 2045. So we're facing a real issue, and that numbers of older women living with breast cancer and living longer with their breast cancer is going to increase. And despite this, there are currently few age-specific guidelines for management of breast cancer. And where guidelines do exist, for example, a guideline from the International Society of Geriatric Oncology on this topic, the guideline is based on relatively low levels of evidence and may not be used in practice throughout the UK, but also worldwide. This is a situation specifically in the UK. The bar at the top depicts our prediction for 2040, and the bar at the bottom, the current situation. And all of the ladies in pink are the ones aged greater than 65. So specifically in the UK, we're going to have a population of over 75% of women living with their breast cancer being over the age of 65, which is a massive change to how we see things at the moment. So there are lots of issues, clearly, between older and younger women with breast cancer, and it's not possible to cover them all today. But one of the biggest issues that we have is really who should have surgery and who shouldn't. And that is, I would say, probably the biggest issue in our older breast cancer population. So on the screen, you can see two ladies here who are both 80 years of age. And if anybody has heard me talk before, I often show these two ladies as I think it depicts really well that physiological age is not the same as chronological age. So both these ladies are 80 years of age. On the left, you can see a very fit lady. In fact, this is Eileen. She was the oldest lady to run the London Marathon in the UK and still going even beyond her 80th birthday. So clearly a very fit, a very active person. And then on the right side of the screen, you can see a more frail looking 80-year-old lady. She's in a care home. She's got her carer there in a wheelchair. And she's got one of these emergency buttons around her neck. So a picture of a much more frail lady. So who should have surgery out of these two? Just have a think about that. And most of my colleagues usually say, oh, the fit marathon runner, surely she should have an operation. She's very fit and healthy, should be able to get through it okay. And the older, more frail lady, perhaps she shouldn't have an operation. And we're going to talk about why you may be right, but also you may be wrong, actually. So we all know really that no matter where we are in the world, when we talk about surgery for breast cancer, we generally talk about lumpectomy versus mastectomy. And in some of our older, more frail patients who have estrogen receptor positive cancers, we may potentially have the option of giving them primary endocrine therapy. So usually this takes the form of a once a day tablet, an aromatase inhibitor in most cases, which won't get rid of the cancer but could potentially control it for the rest of an older person's life. And this shows really the landmark paper behind our practice for that, which is taken from the Cochrane meta-analysis in 2006, basically comparing primary endocrine therapy to surgery in operable breast cancers. And what this meta-analysis showed is that actually your overall survival, that's the top graph, did not differ particularly between patients who had surgery versus primary endocrine therapy. But if we look at the bottom graph, this is looking at local recurrence or local control. And they found that after about 5 years of treatment, patients who had surgery, as we can imagine, had better local control than patients on endocrine therapy did. But essentially, for up to around 5 years, the outcomes were pretty similar. As I say, this paper was from 2006. More recent studies have found similar findings, really, which leads me on to say that we're 20 years ahead now, exactly, and our life expectancy generally worldwide has increased. So if now I have a lady, let's say, who's the age of 70, and I'm saying that for 5 years, we can give you a pretty good quality of life, whether you have surgery or endocrine therapy. Well, is 5 years life expectancy really enough in this day and age? And I don't think that it is. However, this still plays a really important role for those ladies who are extremely frail and have lots of competing medical issues, which cannot really be improved just by optimal medical management. So it's still an important thing for us to consider, but most of our guidelines say that if a patient can tolerate surgery and you can optimize them to go ahead with surgery, then we should be recommending this. And we'll come back to this later on. Now I'm going to talk a little bit about, well, why that might not be the case for all women based on the biology of their breast cancer. So what breast cancer looks at like under the microscope. And there's a lot that we do know. And as we all know, we base our current treatment decisions on the subtype of breast cancer, whether that's luminal A, B, HER2 positive or triple negative. But something that's really important and that makes primary endocrine therapy a viable option, particularly in our oldest women, is that estrogen receptor positivity increases with age. So we can manipulate that and use that to our advantage in older women. But some work that we've done in Nottingham shows us it's not just the fact that a patient is estrogen receptor positive, but it's the degree of that positivity that really matters. So this is some work done by one of my predecessors in Nottingham. And I want you to focus on graphs D and E. So in these are comparing patients who had primary endocrine therapy to surgery. And in the UK and worldwide, we measure estrogen receptor positivity using a H score, which is a score from 0 to 300, with 0 being estrogen receptor negative and 300 being the most positive it could be. So graph D looks at patients who had estrogen receptor positive cancers but had a H score of less than 250. And E looks at patients who had a H score of greater than 250. And essentially, this study showed that for those with a H score greater than 250, so the most estrogen receptor positive you can get, the outcome from surgery and primary endocrine therapy was very similar. But once your H score starts to decrease, less than 250, then surgery does a lot better. So it's not just the fact that a patient is estrogen receptor positive, but it's that degree of positivity, which I certainly know that in the UK, we don't always consider to this extent when we're making our MDT decisions. So that's really important at a molecular level. What else do we know? We routinely measure progestogen in clinical practice, and most PR positive tumours are also ER positive, as we know, because this indicates that there's an intact ER pathway which helps to make PR. And studies have also shown that there may be a better response to primary endocrine therapy in patients who are also progestogen receptor positive. So perhaps this is something that we should pay more attention to in our MDTs when we are considering primary endocrine therapy. But generally speaking, the biology of breast cancer in older women is less aggressive than in younger women, particularly when it comes to HER2. Positivity decreases with age, which is a good feature for our older ladies who are more likely to have slower growing cancers. So that's really what we know so far, and I'm going to expand on that a lot when we come to the research element. But most centres worldwide will measure those 3 biomarkers routinely in practice now. But despite what we may say about biology and who should have surgery or not, one of the big factors when we're talking about our older ladies with breast cancer is actually what they want to achieve from their treatment. And things are different compared to their younger counterparts. So this was a study again performed in Nottingham where we conducted interviews with patients recently diagnosed with breast cancer, some of them having surgery and some of them having endocrine therapy. And then we repeated those interviews 6 months later on to see if their thoughts about treatments had changed. And no matter what treatment the patient had, they really described what they called this trade-off. So the risk versus benefits of treatment options. And they really appreciated that they wanted to optimize their quality of life and maintain their independence. And that might not necessarily mean giving them lots of treatment so that they live longer. And it was really important to them that they weren't a burden on their family members and could continue doing everything that they wanted to do. And they were willing to sacrifice some curative treatments in order to do that. And when we look at similar studies in younger women, we find that is quite different in that our younger patients often want to take whatever treatment options they can to try and extend their life expectancy. So this is something really important for us as the treating clinicians to understand when we're having those conversations with patients. But how can we actually measure that in practice? And it is quite difficult. There are lots of different screening tools, scales out there which we can use to try and help us to determine some of these factors, but really it comes up to individual preference. And we've done a lot of work in Nottingham looking at a comprehensive geriatric assessment, so a quantitative tool to measure particular elements that we don't routinely pick up in our breast unit. So things such as their socioeconomic status, the environment in which they're living, their psychological and mental well-being. A large assessment, which is we identify any issues, we can refer them on to the appropriate services. If anybody has used these types of tools before, you may be aware that they are quite cumbersome, they're quite time consuming, and we're not entirely sure what to do with all of the information we get from these tools. So there are some downsides as well. But they are routinely used in other types of medicine and other types of cancers. For example, your esophageal cancers, where the patients really need optimizing before surgery. Overall, our population is living longer, as I said, and the fact that breast cancer has less aggressive biology as we age really plays a part in our treatment decision making. However, we need to balance that against the fact that treatment does impact quality of life. And although breast surgery, particularly in its most simple form, is often seen as a very superficial surgery with few serious side effects and certainly minimal mortality, actually, studies have shown that functional status does decline, particularly with more invasive surgery, but even with your most simple breast surgeries. So it's impossible to say to our patients, you won't be impacted by this surgery, even to us, if it seems like quite a straightforward procedure. So now I'm going to talk about some research that's been done in this area, particularly in the United Kingdom, and how this could apply internationally. So first of all, to talk about the Bridging the Age Gap study, which was a prospective multi-centre cohort study from many institutions in the United Kingdom, with the aim to capture data about ladies over the age of 70 with breast cancer, but actually to capture data about, well, what was actually happening. So we've got some guidelines, we've got some recommendations, but what's happening in the real world, and to design some patient decision support aids to help patients make those complex decisions, mainly deciding between surgery and primary endocrine therapy, but also the decision about whether or not to take chemotherapy if that was offered to them. So at the end of the study, they have generated this tool, which is freely available and can be accessed online. If anybody would find that helpful, if you just Google Age Gap Decision Tool, it will come up. It's very easy and straightforward to use. As I say, there are two tools, one comparing surgery and primary endocrine therapy, and one comparing surgery with and without chemotherapy, where that is indicated. You require the age, grade, size, and nodal status of the patient, some basic information about their comorbidities and level of frailty. And the tool will work out for you what the patient's predictive survival is at 5 and 10 years, if you wish, and show these diagrams, which you can use in your discussion with the patient. So in this example mock-up that I've done here, in the top right, for this particular patient I input into the system, the tool told me that 90 out of 100 women are alive at 5 years if they have surgery, but if they take endocrine therapy, only 79 out of 100 will be alive. So that may or may not be helpful for some patients when you're discussing options with them. A second major piece of work conducted in the UK was the National Audit of Breast Cancer in Older Patients audit, which last reported in 2022. Again, aiming to capture some real-world data about the process of care and outcomes for older patients compared with slightly younger patients. And the audits looked at many factors of management of breast cancer in older patients. But specifically what we found, which is quite interesting, is that although our guidelines say that we should offer primary surgery in the majority of cases, irrespective of age, many older women in the UK were not receiving primary surgery and were having primary endocrine therapy for a variety of reasons, particularly in the most oldest age group, so over the age of 80, which we might expect. And that may be understandable, but the numbers are a lot higher than probably what we thought. So although we may, as doctors and surgeons and oncologists, recommend surgery, it's actually very complex as to why women may or may not have surgery. So let's talk a little bit about the Nottingham Research Programme, which I've alluded to. As I say, we have a specialist interest in managing breast cancer in older women, and there are three main arms of the research programme. One is looking at the detailed biology, so what does the cancer look like under the microscope? One is looking at the geriatric needs, the specific needs of this population which are not routinely captured in practice. And the third arm is looking at the health economics of this all. So what actually is most cost effective? And this is particularly important in the current day and age in the NHS and worldwide in terms of resource utilisation and provision. So we're extremely lucky to have access to this cohort of patients, over 1,700 patients who were routinely treated in Nottingham between 1973 to 2010. These patients were consecutively collected in a data set. They're all older women with invasive early operable breast cancer with no evidence of distant disease, diagnosed with breast cancer. Now, if they had surgery, we have the surgical excision sample. And if they did not have surgery, and in fact for all of the cohort, we have either their core needle biopsy or FNA sample, as well as long-term follow-up data, which was last updated just 2 years ago. So this is a really unique cohort, and to the best of our knowledge, is the only one like this in the world. Why this is so unique and likely to be replicated again? As I say, patients were collected consecutively, which today, with new ethical approvals that are in place, we're unlikely to be able to create something of this kind ever again. Out of this cohort, you can see around about 55% actually didn't have surgery and 45% did. And most of the patients who didn't have surgery did have primary endocrine therapy, but there were a few patients having radiotherapy or no treatment. And we've developed some unique techniques at the University of Nottingham to make the most of this precious tissue resource. So we've developed a new technique to construct tissue microarrays from the core needle biopsy specimens, which means that we can perform analysis of a large number of biomarkers on a really small sample. And this is some pictures there of how we've generated these tissue microarrays. And we've successfully been able to construct nearly 700 tissue microarrays arrays from core needle biopsy specimens and nearly 600 from the surgical specimens. And these are blocks of tissue which we still have and can still have enough tissue there to continue doing extensive biomarker analysis on. Obviously, that tissue is not finite, and there are much more tissue available from the surgical samples, but it's a fantastic resource. So what we know, we routinely measure, as I said, 3 markers in practice, but as usual in medicine, what we don't know is a lot more. And there are actually hundreds of thousands of potential biomarkers on the outside of a cancer cell, which can be really important in determining how one is going to respond to treatment. We've measured this panel of 32 biological markers in all of the tissue microarrays we have available in the surgery and the core needle biopsy specimens. Our decision to measure these markers was based partly on a literature review we did on the subject, but also on some studies we've done in our younger population within Nottingham. So we've successfully measured this panel of biomarkers using immunohistochemistry. This is what one of the tissue microarray samples look like, and I think you can just make out all the little dots in the wax block. So each dot represents a sample from a different patient. When we take a slide from this block and we stain it for a particular marker using immunohistochemistry, it looks like this. And then we can use special imaging analysis to zoom in and look at individual samples. This is taking from the core needle biopsy tissue microarrays. So you can see that all of the different tissues are quite irregular in size, and some of them have taken up this particular stain more than others. I'm now going to highlight some of the key papers and key work that we've got out of the measurement of this panel of markers. First of all, this is a work by my colleague Banafsha Syed, published in 2013, which was looking at measurement of that panel of markers in the surgical tissue microarrays. So all of these patients had surgery. And on the left, Group A, these are the measurement of markers from our cohort of patients over the age of 70. And on the right, Group B, this is the same work done, but in a corresponding group of younger women, so less than the age of 70, again treated in Nottingham with long-term follow-up data. So we were able to measure the same panel of markers, which you can see here on the screen in both samples, and compare with cluster analysis, the different clusters of biological subtypes. So if we start with the younger group, Group B, the clusters you would expect to see there are present. So you've got your luminal A, your luminal B, your triple negatives and your HER2 positives, and a normal like breast cancer within this. There were 5 subtypes. But in the older women, Group A, there were actually 6 subtypes that were identified. And there was a new group, what we have termed low ER luminal cancers, which were distinct in their biological makeup from your luminal cancers and your triple negatives and HER2 overexpressing, in that they had slightly better outcomes than your HER2 positives and your triple negatives, but they weren't quite as good as the luminal groups. And this is depicted in this Kaplan-Meier plot here. So the new subtype we found is the purple line right here in the middle, and you can see it's almost bang in the middle of the other subtype. So it behaved uniquely to our other well-known subtypes. So is this truly a new subtype of breast cancer in older women that's not seen in younger women, and therefore should we treat it slightly differently? This goes on to talk about some work presented by myself in 2020, which is essentially doing the same biomarker analysis, but in the core needle biopsy sample tissue micro arrays. So patients who went on most likely to have primary endocrine therapy. And you can see here a number of markers were found to be statistically significant and associated with a patient's outcome, so breast cancer specific survival. And on multivariate analysis, these 3 markers came out as independently associated with survival. So we know progesterone we routinely measure, Ki67. Some centres in the world do routinely measure Ki67 as part of their subgroup analysis. but there's mucin-1 there as well. Is this a potential new biomarker for helping us to decide who should have surgery or not? And I just wanted to focus on one biomarker out of the panel, which is really interesting, and that's called cyclin E. So cyclin E is a biomarker which is involved in progression of the cell cycle, but overexpression has been associated as a poor outcome marker in breast cancer. And what we found here, so again, this is a survival plot looking at breast cancer specific survival up to 20 years of follow-up data. And this is in our older women and in patients who were negative for the marker cyclin E, that's the black line at the top, patients who were positive for the marker cyclin E as a graph at the bottom. And you can see quite clearly that in patients who were negative for cyclin E, they were extremely unlikely to die from their breast cancer up to 20 years of follow-up compared with patients who were positive for the expression of cyclin E. So could cyclin E be a specific marker for predicting survival in breast cancer? And this is irrespective of what treatment they had. So that is a really interesting finding. What are we actually going to do with this large amount of biological data that we have? As I say, it's all currently used in a research setting, but we have started putting together a bit of an algorithm as to what to do with this complex data. And the idea would be a little bit like what I've shown you with bridging the age gap or other such tools where you can input some specific data and it gives you an output you can use in practice. So the graph at the bottom here just shows an example of breast cancer specific survival. The line in blue is what happened to the patients in real life, and the line in red is breast cancer specific survival as predicted by our algorithm. And you can see that there's pretty good alignment, but there's still some improvements to make, and that's what we're working on at the moment, something that could actually be used potentially in clinical practice. Now, I've talked a little bit about biology, and I'm going to focus a little bit more now on surgery and different types of surgery and how that plays in. So I'm pleased to say that things have come on a long way in surgical practice. And I often show this picture to my medical students. This was a Persian queen from 500 BC called Queen Atossa, who seems to be the first documented case of breast cancer that we can find, and it was noted that she had this affliction of the breast, a growth there, and they burnt it out of the body. I'm pleased to say things have come on a long way since then. First of all, performing our radical mastectomies, and now what we would call a simple mastectomy today, but also moving on to more complex reconstruction techniques, both after mastectomy and oncoplastic breast conserving surgery. So what we offer to all of our patients in general nowadays looks a bit like this. There are in fact many different options, partly depending on the patient, their wishes, but also their body shape and size and cancer factors as well. Now, why is that of particular importance to older women? Reconstruction clearly means different goals of treatment, goals of reconstruction are different by age and many other factors. But we do know that reconstruction, and I use that term here to describe mastectomy, but also oncoplastic breast conserving surgery, does improve patients' quality of life. And we've talked about how that's really important for our older patients. And it's now become an important part of most of our longer. So it's really important that they make the right surgical choice for them. And we have many, many options. I think historically we used to say, well, why does it really matter for older patients whether or not they have reconstruction? And that may be true, but we've done some work in Nottingham looking at this. So 3 main pieces of work I want to talk about. The first one was a literature review published by my colleague Miss Lee, looking at the uptake of immediate breast reconstruction in older women after mastectomy. And the main findings are displayed here. Essentially, in all of the literature looking at post-mastectomy immediate breast reconstruction, to start off with, generally, as we know from other clinical trials, there are not as many older women included in these types of papers as younger women, so about 1/3 to 2/3 ratio. And in the older women that were only 10% underwent reconstruction compared to 45% of younger women. But few of the studies actually aim to identify and explore the factors behind that. The second piece of work was another literature review published by Ms Chia, looking at the same question but in oncoplastic breast conserving surgery, but the findings were pretty similar. There were even less older women included in these types of studies, and only a small number undergoing these more complex techniques. So the third piece of work, after the literature reviews, we said, well, that's maybe true from the literature, but actually what does the real world data show us? And in conjunction with our colleagues from the European Society of Breast Cancer Specialists, EUSOMA, we were able to access a European database of real world data to answer the same question. So looking at uptake of post-mastectomy immediate breast reconstruction. And really the findings were reflective of what we saw in the literature. So first of all, there are less older women included in the data set, but this really is the take-home message that the percentage of women without reconstruction in older women was much less compared to our younger cohort, so 14% compared to 70%. So there really is a big difference, but again, the reasons for that were not entirely clear. So yes, it may seem obvious to us that perhaps older women just don't want these more complex techniques or want to have surgery at all. But actually, it's more likely to be much more complex from that. And we've looked at three main areas around this. One is our factors associated with us as the treating clinicians. Is there some bias in the way that we present options to patients? We assume that they don't want these options. Could it be in the information that we provide them? Of course, there are some patient-associated factors, and age is one of them, whether you're looking at that chronologically or physiologically. But also there are other factors in terms of their comorbidities and also their thoughts about reconstruction as well. And finally, there are some system-associated factors which will be different across the world, but some of the issues that might happen depending on the healthcare system that you have is related to the insurance status of the patient, but also the location of the hospital. So, for example, in the United Kingdom, we don't offer every type of surgery or reconstruction at every single centre, so the patient may need to travel, and that may be a barrier for them. So this is something we're looking into in more detail. And the next step will be to further explore this disparity by actually talking to some older patients who may or may not have had reconstruction and the reasons why. And also, is there anything that we can do to help address these problems? So the third area from our research program is looking at the health economics of it all, and this is done in conjunction with our colleagues from the University of Manchester. Two key papers there for anybody that's interested, and I've taken these graphs from those papers. But essentially, it will come as no surprise. The table at the top is telling us that the more frail a patient is, the more likely they are to die from their breast cancer, but also to die from any other cause. And then when we look in the bottom table at patients who are having primary endocrine therapy compared to surgery, that level of frailty still remains. So the more frail a patient is, the more likely they are to have run into a problem from either treatment. But actually, in our more frail patients, their all-cause mortality is much greater. Particularly if they're having surgery. So something for us to consider in our healthcare environments. So the last couple of slides before we move on, if anybody's got any questions, or just to talk about what's the future going to hold. So let's go back to these two ladies that I showed at the beginning, and I said, oh, who do you think should have surgery? And I'm sure the majority of you thought that the fit marathon runner on the left would be the surgical candidate, and that may be true, but hopefully I've shown that the picture is much more complex than that. It may be that the fit marathon runner actually has a type of breast cancer that we can tell on biological assessment responds really well to endocrine therapy. And she might want to take that as an option because it means that she doesn't need to have any time off from running or from her activities to have surgery. There's no risk of her losing any of her independence or her fitness from any of the surgical treatments we might give her. And actually, the lady on the right, we might be able to tell from her biological assessment that she has a type of breast cancer that actually doesn't respond very well to endocrine therapy and is likely to progress on that. And actually, she's already in an environment where she feels very well supported. She has 24-hour care. And is not worried about losing that independence because she already has that support there. So actually, it's a lot more complicated than what we take at face value. And ultimately, the future is going to be a combination of what we have termed biological and geriatric assessment and putting all those thoughts together to decide the right treatment for the right patient. What might we see in the future? I think I've highlighted that the biology of older women with breast cancer is different and can be difficult to interpret in clinical practice alongside what the patient wants. And what I've not gone into detail about today, but one of the really important factors is related to the patient's ethnicity and their socio-economic biology of breast cancer, different by different ethnicities, but also what they want from their treatment and their preconceived cultural ideas are different. And if anybody's interested, that might be an opportunity for collaboration across countries in the future. But ultimately, this leads to the question, well, should this impact the treatment we offer, or should we continue to treat everybody irrespective of their age, of which there's still no clear answer, I would say. So thank you very much for listening. That's the end of the presentation. I'd just like to say thank you to some of my colleagues pictured here, who I work very closely with, and some of the collaborators I mentioned throughout the presentation, who without this work would not be possible. Very happy to be contacted by email now or in the future if anybody wants to get in touch or has any questions. And I'm going to stop sharing.
Thank you very much, Ruth. That is a really an eye-opening presentation. And you clearly covered all the areas and the nuances and also the future direction in this area. We do have a few questions. We'll just go through them. One of the questions was that now, say if it's a patient who is planned for or fit enough to undergo surgery as per guidelines practiced in most countries. Would you recommend a de-escalation of the axilla in terms of using the sound trial more freely and other new trial evidence and avoid axillary staging in total? Is that something that you would practice?
I think that's a really good question and one of which I won't have the answer to. And I know a few sessions ago you had my colleague Mr. Goyle talk about management of the axilla, and this is a hot topic, which I think is going to change over the next few years. So I can tell you a little bit about what we do in our unit and how I see this. Particularly in our older patients who are more frail, yes, we will consider removing sentinel lymph node biopsy from their pathway. And we are now really also exploring in some patients who may not be fit enough for a general anaesthetic, whether we can do more techniques using regional anaesthesia or local anaesthesia, in which case we would usually omit sentinel lymph node biopsy. So we're certainly moving towards that, but my feeling is we can do more work in this area. And in the UK, we're expecting some key guidelines to be published later this year, which are from the Association of Breast Surgery. And I think once those guidelines are out, then practice will significantly change. I think it's important to note, and I'm sure Mr. Goyle also mentioned this, for these type of work, looking at de-escalation of techniques. So whether that's after neoadjuvant chemotherapy or in the primary setting, it's really important to keep your data about this and insert it into a registry. And that there's a number that we're involved with in the UK if anybody's interested.
Splendid. I was the next question I think you actually did touch upon in your answer. Myself, I have come across situations where we had to perform a local mastectomy sometimes because of a fungating tumor that's bleeding. Patient is not at all fit for any form of anesthesia, maybe under sedation, maybe under local anesthetics. Is there any sort of enough maybe case series of published data that would say this is something practical and feasible and should be offered?
Mm. Yeah, another great question, and unfortunately, the published literature in this area is of a low level of evidence. And actually, my team we are in the process of writing a paper looking at basically it was a literature review looking at local regional anaesthetic techniques in older women, and we've struggled to come to any firm conclusions because there's not a lot of evidence out there. But there are numbers of case series and case reports, as you say, which essentially leads us to say that there may be some benefits for local regional anaesthesia in these patients, particularly as you describe in your older, more frail patients who cannot have surgery in any other way. It can provide both local control and an improved quality of life for them. So I think it's really important on a practical level to have a good working relationship with your anaesthetic colleagues who perform these techniques. So we're very lucky where I work, and that we're kind of expanding in this area, and we have two consultant anaesthetists who have a specialist interest in performing regional blocks. And will help us to perform mastectomies in these sorts of circumstances. And my own personal experience across a number of hospitals where I've worked in using local anaesthesia for removal of palpable lesions. So let's say, for example, your older person who ordinarily you would ask to have primary endocrine therapy, but actually they have a triple negative cancer. But it's a small cancer and it's palpable. If you could remove this using a local anesthetic technique and then they don't require any other treatment, that has significant impact on the patient physically, mentally, but also from a health economics perspective. It means we've essentially dealt with their cancer and hopefully it won't come back.
I think that's a great answer. Plus, I would like to take from that answer, if it's somebody like who is not suitable for aromatase inhibitors, anastrozole or letrozole, would you rather go for a tamoxifen, or would offering very sort of a localized limited surgery would be a better option?
These are all fantastic questions. And, part of the work that I do, there's not a lot of guidelines or work in this area. So I think, no matter what, the take-home message is that we need to make really nuanced decisions about these patients with our MDT, but also with the patient himself and what would they rather. So I've seen, both sides of the tale. You've got somebody in primary endocrine therapy. They've progressed on 3 or 4 different agents, and then they come to the situation where the only option is surgery, and you think, well, should we have just done that in the first place? But also, you get the older people who've been on the same endocrine agent for 10 years with no issues. So part of our work is looking at, well, can we help to predict that, which I think would change things. But on a practical level. My personal practice is if I see a patient on primary endocrine therapy, every time we see them, I use that as an opportunity to say, are you still happy with your decision? Would you like to reconsider surgery? Is there anything we can do from an optimization perspective for that? So, to revisit those options. because I think in the past, and again from some work we've done locally looking at reasons why patients end up on primary endocrine therapy, quite often the patient sees it as, oh, I'm going to avoid surgery. That's a good option for me. That's what I want. But perhaps we don't explore in detail the potential for what can happen in the future. So in summary, it's very complex. I don't have a particular preference, but I would revisit the option of surgery with that patient, take into account what we can do from a medical perspective to optimize them, but ultimately, what does the patient want? And if you're having that very frank discussion with them, and you come to a conclusion together about what's best for them, I think that's the best thing you can do.
Brilliant. One more question. I think last two questions for sure. It's a situation I'm currently facing, bilateral breast disease. I think it's quite common in the older population. So if
Mm,
a lady presents, especially in a resource limited setup like Sri Lanka, where the patient has obviously T3 or T2 breast cancer and with axillary metastasis, and also with an axillary
mm,
met on the opposite side. Let's say we've done
mm,
a true biopsy from that, and the biopsy is a different kind of a immunoprofile, so suggestive of a two separate malignancies. But the breast on the other side is
mm,
completely normal. On imaging that's available, mammogram ultrasound is normal. But there are no neck nodes, nothing that shows a contiguous
mm.
spread. What kind of a sort of evidence-based approach should we take, or is there any evidence, or do we, like for example, now this particular patient we discussed at the MDT, the
Mm. So
question
yeah, just to make sure I understand, so they've got bilateral axillary involvement and unilateral breast cancer, but the pathologies look to be different.
exactly, yeah,
I
and
yeah,
patient is
I
not for
get that.
neoadjuvant, not fit for
Yeah, the
neoadjuvant.
the evidence is limited, and this would be a discussion, yeah, to take with. Well, we wouldn't know, yeah, not for neoadjuvant, but I think again, it's a discussion to have with your MDT and the patient, depending on what the histology showed. We might, if you're thinking one of them is estrogen receptor negative, I assume that's what you're alluding to. Then we would most likely offer surgery, but what's that surgery going to be? It depends a little bit on what the patient wants and how they are. In this scenario, we know they've got confirmed nodal metastasis, but what is their nodal burden? So here at Derby, we've started doing targeted axillary dissection. So for patients who have clinically N1 disease, so there's what you think there's one or two lymph glands there on ultrasound. And historically, we would have offered them an axillary node clearance. Now we are offering them targeted axillary dissection, so essentially a sentinel node biopsy plus removal of the marked node. So this is talking about de-escalation of treatment, so a smaller procedure to see if they can avoid the morbidity from axillary
I-
node
Isn't
clearance.
it isn't it
So
after
probably.
isn't it after
Mhm.
neoadjuvant the
No,
target?
so we're offering it in the primary setting now.
All right.
So that it is separate. And a little bit of a plug, if anybody else is doing that, we have started a registry called the Node Smart Registry where we're capturing data from these patients. So these are patients not having neoadjuvant therapy and are having primary surgery. Yeah, so I probably offer that to them, but of course it's a discussion with the patient, and you need to weigh up, particularly in our older patients, or if we don't give you any treatment, what's likely to happen, and I think that's a really frank discussion to have. You've also got things, like is radiotherapy an option, which we haven't got time to talk about today, but something we'd chat to our oncologists about.
Okay, last question. Um, so what is likelihood if you have offered a mastectomy, especially for an older lady who usually wouldn't, as your data suggested, wouldn't go for a reconstruction, the likelihood in your setup to ask for symmetrizing mastectomy on the other side?
Mm. Mm. Yeah, another great question, and practice is variable, so I'm often surprised, actually. And I think we as healthcare professionals, as I mentioned in my talk, we sometimes say, "Well, the patient." An older woman won't want reconstruction, but you do meet older women who are very clear in their minds. They've lived with their breasts all of their life. They're almost more attached to them, and they can't see a life without some kind of reconstruction. So I think in older patients, maybe not reconstruction as we see it in terms of implants and autologous reconstruction, but quite often, if they're having a simple mastectomy on one side, we do get a number of requests for a simple reduction on the other side, something like a melon slice, to make them slightly more symmetrical, but still maintain, the kind of their own tissue. So that's something I think we're seeing more of in our older population. I haven't got any data from that. That's just my personal experience. But you do. I have had a number of older women that will say, "I'm not going to have a mastectomy unless I can have reconstruction," and they feel so strongly about that they will not have surgery, and they're willing to accept the risks of not having surgery if they can't have their reconstruction. But I suspect that will differ throughout the world, and a lot of that is based on kind of a person's cultural and other perceptions of body image, isn't it?
All right, thank you very much, Ruth. I think that was a really enlightening discussion, and I think the take-home message here is that it's the decisions aren't clear cut. There's a lot to consider: patient factors, patient preference, frailty, etc. Before we finish this, any final thoughts about the topic?
No, I think my summary will just be, we need to take these patients on a case-by-case basis, discuss with our multidisciplinary team, but also the patient and their caregivers as to what they really want from their treatments.
Right. Thank you very much, Ruth. Thank you for joining with this webinar. I think we learned a lot, and the future direction, especially the cyclin E and the future prospects, and hopefully we can collaborate and do a research with Sri Lanka and your center as well. Thank you. Thank you for all of you who are joining. Thank you.
That'd be great. Take care. Bye.
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 Bye. Bye.